And congratulations to each and every one of you. That's not an easy task. In addition to that, on April the 23rd, we are going to be hosting a remote treatment stroke center workshop for hospitals that are interested in becoming designated stroke centers. So if you or any of your affiliate hospitals are interested, we do not offer this workshop very often. So I encourage each and every one of you to go ahead and register if you are interested, because it may be another year and a half before we're able to offer this workshop, and we know that several of you are working on this. Saying that, I just wanted to go back to defect-free care for just a second. When I was reviewing the Georgia data, I just wanted you to know that arrive by 2 and treat by 3, we lost 156 patients on the table that did not receive TPA for whatever reason within that 3-hour window. So I encourage each and every one of you to really drill down on the patients that were missed, even though when we achieve 90 or 80%, we feel very good about that, and that is very good. But we also do want to look at the patients that we missed to see if we can identify any system barriers. Same with dysphagia screen. We've worked very hard with dysphagia screen quality improvement over 2018. We anticipate making a lot of improvements over the next year. So please drill down into your systems and let's hear what these hospitals have to say on how they achieved such an excellent award. Denise?
Thank you, Terry. So first we will be hearing from Piedmont Healthcare. They have kind of collaborated on this presentation. So I believe we have Jay who will be speaking first. And I will be sharing your presentation, Jay, so you can just let me know when to go to your next slide, unless you'd like to share the presentation yourself.
No, you can drive. That'd be fine. Make sure you can hear me though, okay?
Yes, I can hear you.
Okay.
All right, I'm going to pull it up now.
Should I be seeing it yet?
No, my computer is moving really slow. Just one moment. All right. So you should be seeing it now.
Okay. I've only got a message that you've started to share.
Denise, this is Terry. I can see it, Denise.
Okay.
Okay, here it is. I got it now on mine.
Okay. Too. All right.
Okay, well, we'll drive on then. My name is Jay Connelly. I'm with the Piedmont Henry Hospital. And I think Deb Camp is on the phone as well from Piedmont Noonan Hospital. Taylor Esdell from Atlanta and Lisa from Fayette were unable to be on the call today because of previous engagements. But they were actually our 2 hospitals that did receive the award. Both Deb and I, from a system perspective, we were at 91, and Deb was she missed about 1 month of getting the award. So we all worked together on it. I think that's an important piece to stress as we move forward. We have grown substantially in the last 2 years within the Piedmont system, but the majority of the initiatives that you'll hear about today were initiated mostly between Piedmont Fayette, Piedmont Noonan, Piedmont Atlanta, and Piedmont Fayette, Noonan, Atlanta, and Henry. As we began the journey with this, and now we've incorporated several more hospitals in that are also joining on this. But in 2014, we decided to formalize a system of care within the Piedmont system to just try to ultimately with the goal of improving and providing the same care regardless of which portal of entry you came in through on any of our hospitals. We set up the committee of the 4 of us mostly that worked together, reviewed, analyzed all the programs that we had in place. We looked for all of our opportunities, and then we wanted to drive just clinical improvement.
Who?
If you could please mute your line as to not interrupt the presentation, please.
So then we looked at ways to monitor this compliance and then, revise and move forward as we saw some chances to improve. Can you go to the next slide? So what we did assign a clinical improvement specialist, and we are fortunate enough that we have corporate support with this to help guide our practices as well. We did decide that Fayette, Henry, Atlanta, and Noonan, as you see there, all of our stroke rooms would take a system approach to designing our processes. We did incorporate neurohospitalists.
I'm so sorry.
That's okay. We did incorporate neurohospitalists at each of our facilities, and I think a big piece of it, we also created a stroke medical director, who's Dr. Fernandez for our system, that helped to oversee all of the process that we have, but it was also our ear in communicating with all of the neurologists, and he works very closely with us on weekly and monthly calls if we have them to help with. Of course, like many of you do, interdisciplinary rounds on our stroke units, and then monthly stroke outcome meetings. And we think that this helped us a lot to help us standardize our order sets, standardize the management of our patients when they came in with the strokes. The biggest piece of this was we really did come at it as a team, and regardless of which hospital was seeing some challenges, we kind of went at it as a four-headed monster to try to create better care at all of our hospitals, because knowing that each of us experienced so many of the same problems. And then we developed some scorecards that would help guide us in the right direction and let us see our improvements or challenges across time. Okay, next slide. So where we came from with our clinical improvement stuff, the project that we have completed, we did have a systemized stroke abstractor. I think that helped a lot. Number one, it took a lot of the work off of us, truthfully, to allow us to get out to the bedside and improve patient care. The second thing that it gives us, it gave us a reliability across our system that all charts were being abstracted in the exact same manner. So that helps us to compare. I think sometimes within systems we start challenging, well, she doesn't count that or he doesn't count that. So we went to a system abstraction, and that kind of took all that out of play. So we're now we really are comparing apples to apples, especially within the Piedmont system. We do have a facility-specific quality scorecards that help guide our practices and see where we've come from. We implemented a stroke navigator within the Epic system. We're on Epic here within the Piedmont system. That allows us to guide through the entire stroke process. And you can see a picture of that on the slide there, from the documentation of the stroke starts all the way to the stroke documentation ending, and everything that's needed in between there, especially in the acute management of a stroke. So those nurses that sometimes may not frequently do this, if they ever get stuck, it's just a kind of a gold mine of information for them to key them in what needs to be done next, to assure that we give the same care across the system. We did create an electronic quality measure for those of you that might be struggling with that or starting that journey or in the middle of that journey. But we affected the electronic quality measure dashboard as well, so we keep an eye on those that are directly pulled from our medical records that we don't have a chance to put our fingers on. They come specifically from the chart. Our physician stroke documentation templates, I think this was a huge win for the system in that most of our neurologists document in the exact same manner. The dot phrases that were built within the Epic system actually cue them into those requirement pieces of documentation. Time with which provider saw, decision time, time to give out the place. If the NIH was 6 or greater, which was our protocol, did they consider transfer to a comprehensive center for a potential embolectomy? And then if there were any delays in out to place given outside of 45 minutes, which we're now changing to 30 minutes, what were the reasons for delay and documented delay? So that helped to guide them in all of the requirements that we need from them specifically in those early stages of the stroke care. Our stat team pathways and standardized stroke education, we pushed them out specifically for our in-house strokes. We really were struggling a little bit, but having the stat team on board to help with movement of the patients through the system on the inpatient side has really been a big help for us. And then our stroke education, we've created, well, with Deb's help and a lot of people on this phone call's help, to create the Georgia Stroke Core Curriculum as our primary education for stroke care, and then each of the health stream models that we have built inside of it. And then we have provider abstraction education, telestroke program, and a systemized approach when we do our D&B findings. And I truly think that last piece is what's taken us almost to the next level. If a finding happens at Noonan or a finding happens at Fayette, we take that finding here at Henry as if it happened at our facility. And we put in the same changes that are going to be put in Noonan. We put those in here at Henry. They put it in Atlanta. So that we can try to attack this and learn from each other and not have to spend years of getting the same findings. So we really do take a systemized approach. Each of us go to each of our, so for a month solid, we're doing D&B surveys and walking with our colleagues around their hospitals to find stuff that we can improve on. But at the end of the day, each of the findings, opportunities for improvement, all of that we take as if it happened to our hospital, whether or not it did. So I think that that's helped us move us quickly to where we are today. Next slide. So our defect-free care improvements, specifically to those that we get the awards for. With dysphagia screening, we were seeing that some of our posterior strokes specifically were jumping out and grabbing us a little bit, those dizzies that come in. A little hypertensive. We would see clonidine antivert specifically given early in the game, and then 45 minutes later thinking, ooh, could be a posterior stroke. So we put some Pyxis alerts in on those to alert those of dysphagia screen requirements anytime they give aspirin, clonidine, and antivert. So the Pyxis will alert them to make sure that they complete that swallow screen prior to giving any of those medicines, PO. The full swallow screen for any neuro patient. So we did expand that window to try to catch more of the patients early in the game. So our atypical presentations, our altered mental statuses, our dizziness, our headaches, and any of those with a, quotation mark, neuro complaint, NED would receive a swallow screen before anything PO. We did have mandatory swallow screens added to the inpatient services side. So if they happen to sneak through the emergency department without a swallow screen completed, we complete those on the inpatient floor with our admission process. The stroke education piece, we do have a stroke template in our education within the EPIC system that lists stroke booklet given, and it lists all of the 5 core measures that we educate on within that, so it makes it to the EPIC chart. We've developed a single booklet that we use across the system that educates on both ischemic strokes versus hemorrhagic strokes versus all those risk factors that can be modified, and those non-modifiable risk factors that we just need to be aware of and how to react. It's fast-based. So that we can do identification early for secondary stroke prevention. IV alteplase, we review these monthly in addition to concurrently, but they are reviewed at our case meeting, at our stroke meetings at each of our facilities so that we can learn from any delays in alteplase being given from door to needle perspective. And we're kind of happy to say, we've had several within the system, sub-20 administrations. So we think we're going in the right direction with moving our patients to get alteplase on board even quicker. Discharge on statins, we've created or used, I guess, we didn't really create it, but we've started to use the best practice alerts for anybody that has LDL dysfunction that needs a statin. They have a BPA that fires if there's one not ordered at discharge, so it alerts IMS and those discharging providers the need of a statin when indicated. Our VT prophylaxis, our order set includes both pharmacological and mechanical VT prophylaxis. So we're able to catch it on both sides, and we stress the use of both of those for the management of VT prevention. Rehab considered, our PTOT and speech are all included on our initial protocol, and we require them to have that evaluation done within that first 24 hours as long as the patient's hemodynamically stable. Anticoagulation, the same thing we did with statins, we did with our anticoagulation for best practice alerts being fired if it's not ordered on discharge. Early antithrombotics, we catch a lot of these with order set utilization. It is pre-checked for an antithrombotic in the game, but our concurrent reviews and our neurohospitalist consult also assist in catching those early in the game to make sure that we get those on board. And the big key in that is, always educating our neurohospitalists and neuro mid-levels to what the core measures are and understanding and being able to quote them like their last name so that we make sure they're aware of all that needs to be done. The antithrombotics at discharge, again, the same thing we put in with the other two that are required on discharge was a best practice that would fire. If it's not ordered, our neurohospitals also make sure in their notes that they recommend any medications for discharge, or in fact place them there if they need it on their way out the door. Smoking cessation, our discharge instructions actually include smoking cessation for all of our education. So we're able to accomplish that measure via our discharge instructions that include a small paragraph about smoking cessation and the importance of that. I think the next slide and then one more and I'll be done. So daily tasks and kind of all of our jobs, and you see that picture of us, and we stuck our DNV surveyor there in the middle. Some of you may recognize him if he comes to you guys. And but this is our team from abstraction to our system support, and then Deb, Lisa, Taylor, and I at one of our DNV surveys. But we do concurrent patient audits every single day, just like I guess everybody on this call probably. But we do able to provide immediate feedback to our staff, physicians, any fallouts, victories, successes that we have. We have specific out-of-place audits that we do on each of our patients to assure timeliness of assessments, make sure parameters are met inside of those parameters, and if they're not met, that actions are taken. DNV findings and action plans, as I said earlier, we take this on as everything. You know, I had one finding last year here at our facility, but we put action plans in for, 5 that we received throughout the system, and opportunities for improvement, I guess, is a better word for that, to make sure that we were all doing it the same way. We do have some entity-specific improvements because, like most of us, even though we're in the system, we have some nuances that are a little bit different within each of our hospitals. So we did allow for some of that individuality for some entity-specific improvements. Case reviews nonstop. We do them all the time. Stroke committee meetings. Each hospital meets monthly, where they discuss both system scorecards, hospital-specific scorecards, and then any learnings from the last month that we can share forth. Our community outreach is extensive. We do, we do as much as most of you guys on here. It seems like we're doing 2 or 3 things every week to get out to the community to get early detection, so they can get to the hospital quicker, so that we're able to use all the tools in our toolbox to make sure that we had it. Coding follow-ups, this helps us a lot in relationship to being able to be assured that those that are having the requirements are also coded correctly. We have some of our strokes that go out to get coded stroke, but yet we ruled it out with MRI and symptoms lasted longer than, the 24, 48 hours. So we rule out TIAs and both of them at the same time. So we make sure we do coding reviews to make sure that we don't have any of those still making it to our box. And I think our last slide is a picture of as we've expanded. So you see Lisa there on the left, and Deb and myself and Taylor. That was the original 4, but then in this picture we've included both Rockdale and Athens into the program. And you can see each of us there with our awards at one of the banquets that we were at. But now we've incorporated a couple remote centers that we're beginning to get off the ground. And we've expanded now out to 11 hospitals within the system. So hopefully we'll be able to maintain this system approach across all 11 hospitals, so that we can kind of provide the same level of care across the system. And that's how we got there. I know Deb's on if anybody has any questions for any of us, or emails, or I'm not sure how the question piece of this works at the end.
We have just a few minutes for some questions. Does anyone have any questions for Jay or Deb or anyone? You will have to unmute yourself if you have any questions.
This is Terry. Jay, which dysphagia screening tool did you all implement, and why did you choose that particular tool?
Well, I'll tell you what, Deb, you on the phone, I may defer that one to Deb. She did a lot of work with the speech therapist there. You on there, Deb?
Yeah, I'm here. It wasn't a name of a specific one. It was actually the same one that we used over at Atlanta Medical Center. And when we came here, the speech therapist went through it, and it's not as fancy as what they have done over at Cobb. And, you know, Liz could go through an awesome program that she gave us when we were at GCASR the last time. But it's the same one as far as, but it is a 3-watt, you know, it's a 3-sip type thing. I don't know a name for it or anything, Terry, but they had, you know, that's how it's set up.
It was on the Massey, if it's the one that you used when you were tenant.
Okay, that's what it is then.
Great, thank you. And I have one, if you don't mind. Can you tell us how you engaged your physicians in the emergency room and how you hold them accountable?
Well, I tell you, you want me to go first, Deb?
Please.
So we are fortunate enough at one of our entities, Piedmont Fayette, Dr. Fernandez went physician to physician with the ED docs. And it's pretty impressive to see that not the majority, I won't say, but a vast number of those patients, his notification of out to place is that we gave it. And I think a lot of that is he took all the fear away from those guys in relationship to getting them involved and being educated on out to place and being able to give it. For the rest of the times here at Henry specifically, and I know in Atlanta as well, because I cover a lot for when Taylor's out. But I think it's accountability from a physician leader, and we're fortunate enough at both places with Dr. Sue at Atlanta and Dr. Watkins here at Piedmont Henry. Our medical director for the stroke program was an ER physician until 2 years ago when Dr. Penix came on. So we had Dr. Towater was one of our ER physicians, and incorporating them in, I think, was the best piece. They're at every single meeting and incorporated in, and then being in the emergency department with them. We're down there a lot, walking them through it, taking away any anxieties, and then creating tools that are easy for them. They use .phh stroke for here at Henry, and it incorporates all of the measures that are required with, you know, a couple clicks of the mouse, and they've got everything that they need from documentation perspective. So I think just having them involved in our teams and truly active members, which also comes from leadership support, senior leadership here. We'll definitely ask them where they are if they're not at the meeting. So I think that a little bit of teeth in the request to be there helps, specifically here at Henry.
Thank you. We're actually gonna move to the next presentation so that we can stay on time. And then at the end, if we have more questions, we can address those questions. Is Katja Bryant on the call?
Yes, ma'am.
Thank you. And so we'll hear from Katja, and she will be presenting on behalf of Northside Hospital, Cherokee. So please give your undivided attention to Katja, and I will pull up your slides in just a moment.
Thank you. So Northside Cherokee got the award for increase in defect-free care. And same as Piedmont, I will kind of go through what we do to accomplish that defect-free care. It won't be as comprehensive as Piedmont, but sort of the process of what we do to kind of assure that we meet our core measures for our system. And whatever process that we apply at Cherokee is the same process that we apply at all of our hospitals. So when our patients arrive through the emergency room, and once they get admitted, every day we have a set of core measure nurses that basically look through our hospital admissions, and it doesn't really matter whether they are admissions for stroke or any kind of core measure admissions, and kind of discern whether or not they are stroke admissions. And they have done this for a long time, so they, over the years, kind of figured out what are possible stroke admissions as well. So your dizzinesses and altered mental status and headaches and all the other fine things, your UTIs that turn out to be strokes. So they kind of have expanded their horizon to what could be potential strokes, and kind of look through the patients to categorize them into the core measures. But they also do pneumonia and all the other core measures. So they're not just responsible for our stroke core measures. And then they kind of make sure that the core measures are applied to what are just your straightforward core measures. So as they go through these patients, we're lucky that for our stroke patients, they also look for, was there an NIH documented? Did they have a dysphagia screen? And at some of our hospitals, they also look for, was an intensive statin applied to that patient if they meet the criteria. So if their LDL was greater than 70, if they are diabetic, if they have cerebrovascular disease, and that's probably the majority of our patients. So when they find these patients, they send out notifications to the unit to let them know, hey, by the way, you have a patient, and here are your potentials for failures. So the good news is there's not many of them, because we also have things in place on the unit, like core measure, like what Jay was talking about, the narrator or the stroke navigator. We still live in a hybrid system where we have some on the electronic system and some is still a paper checklist or a pink core measure sheet or whatever. I'll talk about that later. But our core measure nurses, and they do this all very early in the morning because they're early risers. So they're here 5 o'clock in the morning running through these admissions and then sending out, hey, you have a patient, they still need a dysphagia screen, or their SCDs are not on, or whatever, or documented. And so when the rest of the crew gets in, they already know kind of what to look for, or it may have already been resolved by the time they look at these patients, which is really great. And then the nurses on their end, they have admission criteria. Once the patient gets up on the floor and they meet certain criteria, they are core measure. And then they get, they start doing their core measure patients just like most of us do. And they know the criteria by, you know, day 2, do all these things. And we used to have a pink core measure sheet, so that was very popular. Now we have changed that to something electronic that gets pulled, and the nurses kind of go by that as a guide. We also have our order sets that kind of help us with that. So that's the daily review that the primary nurse does, which we have in Cerner, which is our electronic medical system. The same goes on to the patient stay, just like everybody else does. We have a dysphagia screen. We use a 3-texture dysphagia screen. Our emergency room uses the 3-ounce water test because the most that they ever give is a medication, so a water test is appropriate, or they keep the patient NPO. And then when the patient arrives on the floor, we use a 3-texture, so it's water, applesauce, and a graham cracker. And if the patient passes, they can put on their diet. That has decreased our waiting times for patients to be put on their diet. And then we follow our normal core measures, just like everybody else. We have intensive statins. Our IMS admits most of our patients. If they're in doubt, neurology makes a recommendation whether or not the patient should be on intensive statins. We had a very nice system built in our old McKesson electronic record where the physician was actually prompted on contraindications for intensive statins. We haven't quite figured that out for our Cerner system yet. It's just so highly functional that we haven't gotten to everything yet, but we will. We work with a system called MIDAS, that is our core measure review system that reports to CMS as well as the Joint Commission. So once these patients go through discharge and are discharged as a primary ICD-10 of a stroke, they fall into our MIDAS record, and that's the first review for core measures, which we have abstractors for. Happens about 4 days after discharge for us. That's how fast the coding happens. At discharge, for us, the process is that the primary nurse kind of works with our supervisors, which are our charge nurses, to make sure that the patient's discharge measures are met, which is antithrombotics, anticoagulants, stroke education, all the rehab services were appropriately met. What we struggle with rehab services is patients who are too mild, basically, they don't have the need, and that the documentation that they do not have a need is in the chart, and are too severe, that they don't get a evaluation because they're too they don't qualify for rehab that way. And other than that, we usually do really well on our core measures for rehab. What are the discharge? Statins, education, and thrombotic. And all that is signed off by the supervisor before the patient gets discharged. Follow-up appointments, either with primary and or with neurology. And then the next step is MIDAS for core measures, and then the patient gets abstracted into the Get Well Guidelines database. So once that is all done, if there is a failure, which is an OFI, an opportunity for improvement that is finalized, it then gets sent back to the unit, hopefully within 30 days. So we can look again to make sure that there's not documentation that we can reconcile that OFI. Sometimes we can, sometimes we cannot. So that's sort of our process for defect-free care. We look at 100% of our TPA administrations. We review them in our stroke committees. We have tri-campus committees, which happens quarterly. We look at all of our TPA cases with the neurologist as well as with the ED physicians. So that's very similar to what other healthcare systems are doing. And we also look at all of our transfers. We work with our comprehensive centers. We meet with them quarterly to kind of talk through cases and see what we can do better. Yeah, so that's our plan. And we do this harmonized throughout the system. So there's not a lot of variances. There's individualized variances, how far our helipad is from each campus. But other than that, we're pretty harmonized between the hospitals. Thank you.
Awesome. Thank you so much, Katja, for presenting today. So if you have any questions for Katja, we'll save those to the end. We do have one more presentation from Augusta University Medical Center. Is Kim on the line?
Yes, I'm here.
Thank you so much. I'm going to pull up your presentation in just one moment.
Thank you.
Okay, Kim, you can go ahead.
Okay, I'm here. Sorry about that.
That's okay.
So being the last presenter, I may repeat some stuff that other facilities are doing. So I'll try not to be too repetitive, but just go through kind of how we have just received the defect-free care. So next slide, please. So just a little about us. We are an academic medical center. We have 5 vascular neurologists, 1 interventional neurologist, 1 vascular neurosurgeon, 2 neurocritical care physicians, the neurology residency, vascular neurology fellowship, endovascular fellowship, which is new to us as of this year, neurosurgery residency, and then we have support from nurse practitioners. One big component that has helped us just get support throughout the entire hospital is that our neurology service chair is one of our vascular neurologists, and he's also our comprehensive stroke program medical director. We have a 20-bed neuro ICU, which is adjacent to our 16-bed neuro unit. Having these 2 right next door to each other is a very, very good thing and a very huge help for us and our staff. Next slide, please. So just a little history. We've been a primary stroke center since 2005, and then in 2013, we became a comprehensive stroke center. 2013, we also decided that it was appropriate for our facility to start doing 100% stroke abstraction. Prior to that, we were doing just the required sampled by Joint Commission. In 2014, we actually started uploading all of 100% of our cases on a bi-monthly, so every 2-week basis. That means that majority of our cases are reviewed within 30 days for final review. Our data is shared monthly with our core stroke team, and any OFIs are just shared with all the individuals involved in the case. So nurses, residents, physicians, up to nurse managers and to our medical director. We also share all of our data at a large comprehensive stroke team meeting that we have quarterly. And this meeting includes all the therapies, pharmacy, lab, all the ancillary departments that help us achieve our defect-free care. And so how we present this on our quarterly basis is we present our compliance percentages compared to the other CSCs that are Joint Commission certified. Next slide, please. So a lot of the challenges are just kind of the same that you've been hearing. So one of our biggest ones is that these measures have been around for a while and people don't like change. They like to do things the way they've been doing things. They think that we're good enough if we're at, 92, 95%. But there's always ways to try to catch those last few patients and make sure that everybody's getting the defect-free care that they deserve. I know for our center, we're also a level 1 trauma, and we do have our STEMI certification at AU. And so we have to just consistently keep stroke in everybody's brain and at the forefront. I mean, it takes a large multidisciplinary team to run stroke and to run stroke successfully, just from the ED to the lab, to the pharmacy, up to the unit, to the floor. Care coordination is just very important. And so we know it takes a lot of time and a lot of resources. And like most facilities right now, those are just two very valuable items. Again, the difficulty getting buy-in from all the other departments. Someone asked earlier about getting, ED buy-in and how do you hold them accountable. We are also lucky enough to have an ED stroke champion, Dr. Gross, who works with us very closely. We have monthly meetings with that core team, and our core stroke team does involve the ED educator, Dr. Gross himself, the ED director, Dr. Shriver, if he's able to be in there, and also the nurse manager of our ED. We do the same with our IR department, our CD department. So those monthly meetings and just having them to have a voice every month is very helpful to us. Communication, that monthly meeting has been very, very beneficial to us. Just able to have a small roundtable meeting with all the core team members and giving everybody a voice. That's been probably insurmountable for us. We started that in January of 2018, and just coming together monthly, having action items away from that meeting. Everybody's comfortable to say what they need to say, and then just on that monthly basis, we're able to come back and make changes on a quick basis. Next slide, please. So how we overcame, and I will try to get into some of the specific measures, but like most people have been saying, concurrent review is huge. I mean, that's probably been one of the biggest things that have allowed us to get to the defect-free care. It's just that continually checking each patient every day, making sure that they are getting the things that they need to get, and also that it's getting documented appropriately. We also have Cerner, so we've built in as many things electronically as we've been able to build in for our nurses and for our residents, including making power plans and forms for our nurses with all the appropriate documentation. Okay, I'm so sorry. We also spot check our charts. We don't just do concurrent review. We go through all of our TPA charts, get checked to make sure vital signs and neuro checks are done appropriately. Like I just spoke about before, we did change the format of our team meeting. We went from a large group monthly meetings to just that smaller core team every month to come around the table. Our opportunities for improvement, much like everyone else shared, we send those out as soon as they are identified to the involved clinicians to kind of give it a second look and see if maybe there's something that our abstractors missed. And it also just gives them time to go through the medical record in a retrospective manner and see what our abstractors see, and also to just dig in deeper to the measures and to learn those as a frontline worker. We did develop a template for our ischemic and hemorrhagic H&Ps, and this just helps to trigger our residents and our attendings just to remember all the different things that have to be documented. We know how many measures we have, and how many standards that we're trying to stay compliant with. And then it's hard for them to remember everything on every patient. So we like to try to trigger to try to help and make things as easy as possible for them. So staff buy-in, we have started to bring in some of our stroke patients and our champions, people who have had great outcomes, people who maybe didn't have so great outcomes, but to come and talk to our meetings and just to be that patient advocate and to share with everybody. It really shows and brings a face to the care that the frontline staff is giving, that they don't always get to see. So that has also been, again, just very good for our frontline staff. And we include the ED, the IR, everybody gets to meet and see those patients. We also send a little bit of a competition for our TPA. We do send out our fastest door to needle time, and we send that out to be posted in the ED and on both of our neuro units. So we like to do that. And we also share feedback posters with EMS for our thrombectomies and for our TPA cases that have images. There's no patient identifiers on these posters, and so they can be placed in our EMS lounge, but just to show people that the care that they provide truly does matter and to put a face to it. And then transparency. Again, we are transparent all the way to our frontline staff up to the board. We share with the board on a quarterly basis all of our measures for stroke. We are required to share with the board our performance improvement activities and what we're doing if any measures are below the current threshold that we're trying to meet. Again, our frontline staff has all of our measure data on a monthly basis, and it is shared individually again, like if there is a specific OFI. Next slide, please. So this is our team. This is our large group meeting, and this is why it's a very good team. We have very good involvement from all departments in this picture. There's EMS, there's rehab, care coordination, quality management, social work. We are a hub and spoke system, and so our telestroke coordinator is in there, our neurologist, our data analyst. So we have a very big, very supportive team, but also decided that on a monthly basis, it's been good for us to drill down with just a smaller team where everybody is comfortable to speak their mind and speak for their department so that we can all make change together. So happy to answer any questions.
Thank you so much, Kim. It sounds like we have a bonus presenter.
You do. I'm so sorry. I'm at home today. Being in Augusta
okay.
this
We
week
appreciate
is difficult, as everyone knows.
That is okay. We appreciate you getting on and still providing us with the presentation. We understand.
Yes, sir.
So thank you again to all of our presenters today. And if you have any questions for either of our presenters, please let us know. And I'm also checking the chat box to see if there are any questions there.
I have a question. This is Jan from Emory.
Yes, Jan, go ahead.
Yes.
Katja earlier was describing the dysphagia screening tool that they're using. And I'd just like for her to clarify, did you say that you offer water and then applesauce and then a cracker? Is that correct?
Yes, ma'am.
Oh, okay.
So in 2014, I think, we did they did an evidence-based study and with speech pathology, and that's the tool we've been using. And we actually did a control study in 2016, I want to say, that we presented, I think we presented at ISC, I know we presented at ISC, to make sure that what the nurses found was accurate to what a speech therapist found, and the correlation was like 89%. So the accuracy, so it validated the screen, so what we're doing is right, and it also helps us, the wait time for a patient is shortened. And I can't tell you exactly how much, but patients won't be kept NPO if they fail their water screen. because we can put them on a regular on their order diet faster if they pass their screens, or if they were on a mechanical software at home, they get it here faster. But I would have to look back on the direction, to get you more details. So I can do that and send that to you.
Okay, so is this in lieu? Would this be because you didn't have access to speech therapy in a timely manner?
No, it wouldn't.
Okay.
No, we have speech therapy 7 days a week.
So I guess, you're just taking it a step further than we would. Like if we here at EUH do a screening on water and they pass, then unless they have a facial droop or something, well, number one, they shouldn't get the dysphagia screen anyway. But if they pass, then we would pass them. We wouldn't go on to step 2 and 3.
Mm-hmm.
So what you're saying is if they pass the water, then you move on to the applesauce and to the—
Correct.
Okay.
Correct.
Okay.
But we may find somebody who may pass water but may not pass the other ones.
I see.
And that may be something that SpeechGen can evaluate, and that correlates really well. That is what correlated really well.
I see. Okay, that's clarification. Thank you.
You're welcome.
That's a great question. We do have one question from Terry. She said she loves how Augusta takes the stroke survivors to all departments. What is the name of Northside's dysphagia screening tool?
So it's a nursing bedside swallow screen. So it's a screening because the evaluation is done by speech, and there's a big back and forth. Is it a dysphagia screening? Is it a swallow screening? As long as it's a screening, we're good to go, because an evaluation is done by speech. And that's all I can tell you. Mm-hmm. And I can send out the evidence by which it was based on. I was not here yet, but there was a lot of literature that went into that.
Okay. And I can share that if you want to send that to me. I can share it with the group. And we do have another question that's in the chat box from Lane Kilpatrick. And it says, other than short on-scene times, accurate documentation, and early activation of a stroke alert, what role does EMS play in Coverdell stroke outcomes currently? And how can we improve the patient outcomes? Who would like to take that question?
So I can speak for AU. Just we've been working with our EMS recently. Georgia doesn't have a statewide EMS algorithm, but we've been working with our local EMS about incorporating the RACE score and using that to call into our ECC, and just helps them and helps us. One thing that we also do, which there's probably other centers who do this, is that our patients, especially within the TPA window, they come straight through our triage and they stay on the EMS scanner until they're on the EMS stretcher to the CT scanner. And so our EMS partners have agreed to do that, and that's been good for our times and our patients.
Okay. Does anyone else want to chime in on that question? Do you have anything different?
This is Jan again from Emory. So there was a test of change done in our ED, but I'm afraid we didn't roll out the education as we should have. So what did you do to prepare for receiving patients straight to the CT scanner?
So I wasn't in my current role when this happened. I was actually in the quality department when we started doing this a few years ago. So I will actually refer that back to our stroke program manager, who cannot be on the call today, Holly Barnes.
Oh, okay.
And have her get back with Denise to give you more detail on that, about how they rolled out the education. So sorry.
Okay. No, thank you.
We've done a lot this is Debbie from Piedmont Noonan, with EMS as far as the education with them, being that Coweta County is our primary source of patients here. We do have a couple other agencies that come here, but it's primarily Coweta County. We've been able to do a lot of education directly with them, and we do the Georgia Stroke Professional class, with the GSC EMS component of it. And we have a weekly call that we do with EMS, so that, and Grady is on the call because that is where most of our patients go for intervention. And we have that weekly call to review all the cases that we have sent either from the field or directly from the hospital. That has helped out a whole lot with the education too.
Deb, do you all send the patient, do you all go to the scanner before you go to a room when the patient arrives by EMS?
We go straight to CT.
So how do you have the CT set up? Do you have it set up with monitors for blood pressure and all the lab and the glucose monitoring and so forth that you need?
Yeah, EMS is awesome, and they keep them on their monitor, so we don't have to make that switch. That saves us some time, and they are actually doing the lab draws in the field for us too.
So you accept their blood sugar?
Their blood sugar and tubes of blood, so for everything. Yeah, they come in with a package of blood tubes for us. We supply the tubes for them, and they actually draw all the bloods. But yeah, they give us their basic glucose, and yes, we repeat it once they get back into the room. If there's a concern or anything, but we have found that there hasn't been any variation with that.
Okay.
So this Katja. Hey Jan, that may not work in Metro Atlanta hospitals because we get patients from multiple EMS agencies to get their tubing. It works well in more in the rural areas where we have, less, variation between EMS agencies. But we do straight to CT as well at Northside, and we take everything basically with us to CT. So we keep them on their EMS, we switch them to our stretcher, but keep them on their monitor. And then we go to CT, physician just kind of takes an ABC look at the patient and then allows them to go. And then we do everything in the scanner. We do have to say, and I don't know, Debbie, how you guys do it, we did kind of switch up our flow a little bit because we have approached it we do CT, CTA, CTP, or CT, CTP, CTA, whichever frequency you do. And we ended up finding that a lot of the stuff that we need to be doing, we actually could pause between the CT and the CTA to kind of get the consent for the dye if you need to, and do our telestroke, put the line in for the second line if you don't have one, do your neuro assessment or do a complete your neuro assessment if you haven't done it, get the results from the head CT to see if there's no blood. If you don't get a wet read, if we don't get a wet read, we don't have always a physician in the scanner. So, I mean, there's variations in how some people do it. Just wanted to share that. Thank you.
Thank you, Katja. And we don't have any other questions in the chat, but we do have time for one more question. Does anyone else have any questions for either of our speakers today? Okay, so thank you all for presenting today, and thank you for your questions. These presentations will be saved and available to you. So I will send out the entire recording to everyone. Again, if you did not enter your facility name in the chat box, please do that so we can have record that you attended the call today. And we will see you guys in June. So we will send out another calendar appointment for that. And just a reminder, if you're interested in attending the Remote Treatment Stroke Center workshop on April 23rd, please you can email either me or Terry, and we can send you the link to the registration. And thank you so much. Have a good day.